Good morning, everyone. Welcome to Forums That Matter, community service of the Unitarian Universalist Congregation of Cleveland. My name is Wayne Jennings, a member of the Forum Committee and coordinator of today's discussion, which has both remote and in-person attendances. Our topic today is the disease that steals the self, understanding Alzheimer's and the fight for a cure. After our speaker's presentation, which will end around 9:35, we will have Q&A until 10 o'clock. Microphones like this one will be available to our in-person audience members, and our virtual attendees should use the Q&A button on their Zoom screen for their questions. It is now my pleasure to introduce our speaker, Dr. Martha Stajatovic, MD. Dr. Stajatovic, and I pronounced it wrong again, Stajatovic, is professor of psychiatry and neurology at Case Western Reserve University School of Medicine in Cleveland, Ohio. She is a researcher, educator, and clinician who has devoted herself to the study and treatment of central nervous system conditions, including Alzheimer's disease and other types of dementia, stroke, epilepsy, Parkinson's disease, as well as mental health disorders. Dr. Stajatovic holds the Willard Brown Chair in Neurological Outcomes at University Hospital's Cleveland Medical Center and directs the Neurological and Behavioral Outcomes Center at Case Western Reserve, UHCMC. That's the University Hospital's Cleveland Medical Center. She has a subspecialty certification in behavioral neurology and neuropsychiatry. So welcome, Dr. Stajatovic.
Thank you, Wayne, and thank you all for inviting me to come and speak with you. I'm always happy to talk about one of my favorite topics is brain health research. I've been doing that for a little while at Case and at university hospitals. What I'm going to talk about this morning is the Cleveland Alzheimer's Disease Research Center, or CADRC is the acronym that we use, which is part of a national effort to try to understand the causes and potentially treatments and eventually cures for Alzheimer's disease. So when we talk about Alzheimer's, it's really important to just not zoom into that disease state, but to step back and think about brain health or body health as a whole. So I'm going to be using the term brain health. I wanted to give you all a definition of it. I think this is about the best of any that I've seen. That brain health is a continuous state of attaining and maintaining the optimal neurologic function that best supports one's physical, mental, and social well-being through every stage of life. So I would say this is something that we all can agree on is, optimal and what we want. On the flip side, dementia, which is the disease state where one does not have brain health, has been defined as a loss of cognitive functioning across multiple domains, thinking, remembering, reasoning. That's something that people don't always appreciate, that it's not just the memory and the recall, but it's the ability to problem solve and look ahead. The symptoms of dementia can vary, but these are some of the most common. So we all think about memory loss as being the hallmark, but wandering and getting lost in a familiar neighborhood. So, when the brain is functioning the way it's supposed to, we see a landmark or we see something that gives us context, and then we know where we are, right, spatially, and can figure out what we want to do. The memory leads to things like repeating questions, but then there's some important other, I would say, non-memory related, losing interest in normal daily activities or functions. People kind of withdraw. And then you can also have physical and neurological kind of manifestations like losing balance, problems with movement. This is where fall risk becomes particularly salient. So when I go around and I talk about the CADRC, I get asked, this is probably one of the most common questions I get asked. And I know that we've got people in healthcare in this audience, so you may be familiar with it, but I think it's just important for us as communities to think about making sure people really understand Dementia, I like this slide because it describes dementia as the umbrella term. And then there's different versions of dementia under that umbrella. So Alzheimer's is the biggest because that's the most common, but there's many other types of conditions that can cause dementia. And when we think about management and treatments and maybe eventually cures, it's important to understand this difference, because a treatment for one of these things that's under the umbrella may not be effective for other subcategories within that umbrella. Alzheimer's is unfortunately a growth industry. Nearly 7 million Americans have this currently. 1 in 9 people age 65 and older has it, and we project really a massive increase. By mid-century, the number of people age 65 and older with AD will nearly triple, going from about 5.5 million to almost 14 million. So really substantial increase. What I show you here is something that you would have found for many, 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 many years in neurology textbooks and reports, is this kind of classic trajectory of Alzheimer's disease, from cognitive symptoms starting to appear. ADL is activities of daily living, so people have a harder time kind of managing what we all need to do to kind of get through our lives, as well as behavioral problems and worsening memory. And that's about, under a decade or close to a decade, more or less. So that traditional trajectory and how we can impact the trajectory is one of the most exciting areas of research in AD currently. So let me step back a little bit and give you a little bit of that, kind of parsing out that standard or classic trajectory. So National Institute of Aging has defined some core clinical criteria. One of them is a change in cognition. So changes in cognition, the way the thinking process can come from multiple sources. It can come from a person who has a condition, the patient. Informants or people that know them are extremely important. So one of the, what can happen very often when people have cognitive decline is they may not appreciate that and be aware of it. So, when we do intakes in the Alzheimer's Disease Research Center, we actually require a care partner to come in, because otherwise you're going to get a very lopsided or biased view of what's been going on. The clinician can certainly notice things, but I would say that tripartite sources of information, the patient, the informant, and the clinician, is really just really critical. You need to see impairment in one or more cognitive domains, so things like memory, executive function, which is problem solving, planning, attention, language, so people will have word finding difficulties, or they may have difficulty expressing themselves, and then visuospatial, so thinking about the getting lost in the neighborhood. Preservation of independence and functional abilities, so that is generally as people start to have decline, we start to look at what kind of impact does that have. So minimal cognitive impairment means they are able to compensate or overcome those deficiencies. This is really just it's an older graphic, but I like to show it because it just shows that the biggest risk factor for dementia in general is greater age. So African Americans are more likely to develop dementia compared to white Americans. Their risk is 2 to 3 times. Latinos are similarly adversely and disproportionately impacted. They make up 17% of the US population, but only 1% of clinical trial research participants. So part of our mission in the CADRC is to try to make sure we have diverse representation of people that are involved in our research. So if you look at racial and ethnic minorities, they're not part of the research, both in developing treatments and looking at trajectories of outcomes. So diversity in enrollment is really critical, and not just for the groups, the subcommunities that are disproportionately impacted, but for all of us, right? Understanding why a particular individual or a group is at greater risk for both the disease occurring and progression is really important when we think about how do we target modifications. So, research center. What is an Alzheimer's disease research center? It is a National Institute of Aging funded network that's been in business since the mid-1980s. There's about 35 of these around the country. Also talking about disproportionate representation. So the dark blue is the states that have centers. Light blue is developing centers, so that's a different mechanism. But you can see there's big swaths of the country where there are no Alzheimer's disease research centers. Our center in Cleveland is the only ADRC in the state of Ohio. We got funded in 2020 after a couple of bridge fund grants. So what is really impressive, and I think important to note about the CADRC, is that it is a virtual center that incorporates all of the major facilities and research powerhouses in our region. So we've got Cleveland Clinic, University Hospitals, Case Western Reserve University School of Medicine, MetroHealth, and more recently, I'm really excited about this, is about a year and a half ago, the VA in Cleveland, Louis Stokes VA, came online as an enrolling site for us. We are only, I think, the fourth CADRC that has the VA, and that's really very beneficial for us and our research.
Good for them.
Good for them, absolutely. Actually, the kudos go to, I have two colleagues at the VA, Dr. PJ Chen and Dr. Murali Palaki, who perseverance, my gosh, if there was a medal for perseverance, it took them 2 years to get through all the bureaucracy. But they were persistent, and that persistence paid off. So let me go back into the issue of the time course of AD, because I think that's important when we think about what can we do. So I showed you earlier that, decade, give or take a few years, kind of classic progression. But if we start to look at what is going on with the brain, what we can see is that what is happening on the cellular level or the biological level happens way before you start to see clinical symptoms. So this is the clinical progression on the right, or on your left, cognitively normal, mild cognitive impairment without functional impairment, and then dementia with different degrees of slide. But actually, if you look at detection threshold, you can actually see biomarkers in the brain, either by neuroimaging that will you look at the brain sort of in total, or biomarkers that are cellular markers, right? You actually have to go in and look at the cell to see that there's changes. And those changes start to happen years and sometimes decades before you start to see clinical manifestations. Can you modify that, right? That progression of both the biomarkers and the clinical symptoms, maybe. So coexisting pathologies, and I'll talk about some of those in a couple of minutes, but things like diabetes can actually move you a little further to your left with earlier progression, or you can actually turn it the other way to your right, where you actually can delay, and the effect of cognitive reserve. So, cells age as we age, and they may or may not result in symptoms and functional decline. There's a variety of things that will allow the brain to compensate on a cellular level, on a whole body level. And that effect of cognitive reserve, I would say, is where the money is for research. So, interventions after symptom onset is too late. So I've showed you how, biological changes happen. Unfortunately, because of stigma related to dementia, very often by the time somebody comes to clinical attention, they've gone to their PCP, they report cognitive impairment. Maybe they don't want to talk about it or present it, especially some of the racial and ethnic minority subgroups that we have in town, big subgroups, there is a hesitancy to go in and get assessment. So by the time somebody comes to clinical attention, they may have moderate or even moderately severe disease, and it's really hard to do much at that point. Interventions are more effective if they're started early for a longer duration. It allows for the implementation of treatments as well as life planning and the option to potentially participate in disease-modifying treatments. So this process here, and I apologize, that's a little bit hard to see, but it goes all the way, how do we do an assessment, make a diagnosis, and then come up with some type of intervention. So history and the examination, the testing via a variety of sources, neuroimaging, patient history, other types of biomarker analysis. Once a diagnosis is made, sharing that with the patient and family, and then counseling regarding treatment options and what does the person want to do. This is some of the components of the evaluation, so a mental status exam, a neurological exam, different types of cognitive screening. So there's brief screenings that can be done in a primary care clinician's office or even online to more detailed neuropsychological assessment. We know a lot more about biomarkers. So in the assessment, there would be some standard medical evaluation testing to identify some of the important comorbidities, diabetes, inflammatory markers, genetic testing. So it has been well established that the ApoE gene is a biomarker for elevated risk of Alzheimer's, and it can be important, is important to know what your risk is. I would say, especially if you have a strong family history. We can do cerebrospinal fluids assessment to look at biomarkers, again, in collaboration with that history, and then neuroimaging, structural neuroimaging that lets you look at the shapes of the brain, the ventricle. There's functional neuroimaging, so you can look at blood flow and brain activity that might give you some indication of what's going on and what type of underlying process this might be. Remember that umbrella? Which type of cognitive impairment or dementia might this be? And those biomarkers, along with a thorough clinical and neurological history, can help you hone in on what is the neurodegenerative condition. There are some FDA-approved biomarkers from the cerebrospinal fluid based on neuroimaging with amyloid PET, tau PET. The current recommendation is that biomarker testing is not recommended for asymptomatic individuals. So I do get people as a neuropsychiatrist where folks come to me and say, I want to be tested for everything. I don't have any symptoms, I want to be tested for everything. So that's not the recommendation at this time, but focused evaluation can be done if there's a specific concern. There are other biomarkers that are in development. So this is an example of some of the findings with neuroimaging that hippocampal, which is a structure in the brain, would be impacted with neurodegenerative conditions that affect memory. And you can see some of that on structural neuroimaging. So diagnosis and staging. So as we've had more intervention, prevention, disease-modifying therapy, it's more important to think about the course of what happens with dementia. So cognitively unimpaired, mild cognitive impairment, the definition of that is you have impairment, but it's not significantly impacting functional decline, and then dementia will also stage from mild, moderate to severe. This is a clinical staging specific to individuals in the Alzheimer's continuum, where it may be more predictable as far as the next stages. What's less predictable is how quickly somebody might proceed through that staging. So specific to AD, stage 0, for instance, is genetically determined Alzheimer's disease. So there are some conditions where we know that there is a risk much early in life that people will develop Alzheimer's disease, and Down syndrome is a good example of that. So trisomy 21 is a clear risk factor for premature AD. And then we have stages all the way to 1 through 6 based on functional and cognitive impairment. So I'm going to shift gears a little bit and talk about intervention and treatment here. How do you protect your brain and help manage dementia or prevent dementia? So it's really about risk factors. Here are some of the common conditions that increase a person's risk for Alzheimer's, stroke, elevated cholesterol, hearing loss, depression, sleep apnea, obesity, heart disease, vision loss, hypertension, diabetes. So all of those are known important risk factors to developing cognitive impairment in AD. A 2024 Lancet Commission focused in on modifiable risk factors. And you can see off to your right, basically sort of the weighting. Nearly half, so 45% of dementia risk is due to potentially modifiable factors. So less education, well known as being a risk factor. So that's where the issue of cognitive reserve comes in. I would say that's modifiable, probably not for people who are older and concerned about cognitive impairment. You've probably got your education under your belt already, but if we think about policy implications and educational indications, anything we can do to educate a child on a population level reduces subsequent risk for Alzheimer's. Hearing loss, elevated LDL cholesterol, depression, protecting your brain. So head injury, traumatic brain injury is a risk factor. And you can see some of the other things. Social isolation, 5% of modifiable risk is social isolation. So it kind of comes together. We all are looking for sort of quick fixes where we could say, oh, just fix this and my risk will be all better. What the data tells us is it's not that simple. There are multiple modifiable factors. And we can think about which ones we can potentially modify. Medications with anticholinergic effects can also increase the risk. So, benzodiazepines, so sedative hypnotics used long-term can increase risk. Chemotherapy, you heard that term, chemo brain. So when we do an evaluation, we look at medications or drugs that a person is on, and can we reduce some of that risk and some of that burden? There was a study that was reported on a while ago now, the Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disabilities. The FINGER study was a 2-year multi-domain lifestyle intervention. It was completed over a decade ago. People at risk for dementia from age 60 to 77, and people were randomized to either get kind of basically control treatment as usual versus this very aggressive multi-component intervention. And what they found is that there were beneficial effects on cognition, regardless of the person's demographic, their cardiovascular risk level, and baseline cognitive performance. So what was this rigorous intervention in FINGER? It was nutrition, good, healthy nutrition, exercise, cognitive training, and optimization of what you can do to minimize cardiovascular risk. Other health modifications that people can do, and this is something that isn't, I wouldn't say dependent on clinicians, it's really dependent on individuals and families, is optimize your blood pressure with goals based on comorbidities and symptoms, checking cholesterol, being aware of cardiometabolic risk, controlling blood sugar, treat depression effectively, clearly a risk factor for Alzheimer's, maintaining a healthy weight, and treating obesity or managing obesity as best possible. Cutting down on medications that have anticholinergic side effects. Screening for hearing loss early on. So people, most cases of hearing loss are pretty insidious. They don't happen all at once. Then the person may not be aware of that. This is one of those situations where family and spouses will often be the ones that are most tuned in. Vision, similarly. Physical activity. So a good goal is walking 30 minutes a day, 5 days a week. That's hard sometimes in places like Cleveland where the weather makes it hard to be outside walking. Mental stimulation. So people ask me, should I do Sudoku or the crossword puzzles? And I say, absolutely. That shouldn't be your one and only thing. Like if you're sitting there as a couch potato and you're doing crossword puzzles, that probably won't cut it. But in that package of care, like we saw in the finger study, it can be helpful. Socialization, book club, churches, temples. So you guys are doing brain health right now. Smoking cessation is never too late to quit, and reducing alcohol intake. So let's go to treatment options. In addition, medication treatment option is in addition to those lifestyle factors. So there are some drugs that have been around for a long time: anti-amyloid therapies, cholinesterase inhibitors, memantine, treatment of contributing factors. This is a little cartoon that identifies some of the current understandings of what causes Alzheimer's. So if you can see there on your bottom right, amyloid plaques and tau tangles are cellular markers of Alzheimer's disease, and some of our new therapies, monoclonal antibodies, address those, but may not necessarily address things further up the food chain. So some of our older drugs like cholinesterase inhibitors and excitotoxicity targets like memantine all address kind of different elements of what we believe to be the causes of Alzheimer's. This is another graphic that just shows the different drug treatments that are approved. So I mentioned the older drugs to your left: donepezil, memantine, monoclonal antibodies way to your right: aducanumab, lecanemab, donanemab. And then we can treat symptoms with behavioral problems that occur in AD with drugs like brexpiprazole, which are second-generation antipsychotics. I would say that's not a treatment that's disease-modifying at all. That's just a symptom treatment. So with our new drugs, the anti-amyloid monoclonal antibodies, the posited mechanism of action is that these drugs target and bind to different epitopes, specific forms of A beta. They activate microglia, so basically kind of clean up those fibrils and plaques. Based on the research and development of these drugs, this is considerations for eligibility. So a person has a diagnosis of mild cognitive impairment or mild dementia. So when we see somebody who has moderate or more severe dementia, they are generally not a candidate. Amyloid positives, because these drugs are amyloid targeting treatments. So they would need to have, based on their neuroimaging, positive amyloid, usually amyloid PET. I mentioned the ApoE, so ApoE4 status. You can have one copy or two copies of those genes, which suggests that you may be at higher risk for progression. 50 to 90 years of age in the clinical trials. Cognitive impairment based on office-based testing, the mini mental status examination or the Montreal cognitive evaluation. BMI between 17 and 35. They can be on some of the other cognitive enhancing drugs, and the person needs to ideally have a care partner, because these are not easy treatments to do. So these amyloid targeting drugs potentially can modify the trajectory of the disease. They could potentially slow progression. However, they are also potentially very problematic in terms of side effects. And it's not uncommon for me and for those of you who may see patients and be in the scenario where people may hear about the side effects and say, that's not what I want to do. So you can get something called amyloid-related imaging abnormalities, or ARIA, which basically is brain inflammation and brain swelling. Up to 40% of people on these therapies can get ARIA. So it's not a trivial side effect by any means. And this is what some of those abnormalities look like with neuroimaging. Sometimes that will require either pausing of treatment or even discontinuation of treatment. So as I mentioned, up to 40%. So it's almost 1 in 2 people that will have this really significant side effects. So then just stepping back a little bit, non-cognitive therapies beyond the amyloid targeting. So I mentioned apathy is something that happens as people have cognitive decline. So social and physical activity, potentially some medications, maybe, managing the symptoms. Irritability, you can see psychosis related to Alzheimer's, and many people have sleep disturbances. So there are different symptomatic medication treatments that can use. But I would say sleep is a really problematic one, right? So we all benefit from a good night's sleep, and it's important to have brain health. But almost all of the drugs that can be prescribed for sleep, sedative hypnotics, can increase risk of all cognitive dulling all by themselves. I would say it's a very delicate seesaw to try to manage. And then just to wind up here, I mentioned stigma as being a significant impediment to people coming in for help. It is unfortunately alive and well. The effects of stigma on a person who has cognitive impairment is that they tend to seclude themselves. They may have depression, anxiety, worry about what's going to happen, loss of social status, embarrassment, shame. You can have something called spillover stigma, where say one spouse is affected and everybody just sort of avoids that couple, which is a really unfortunate impact of stigma that always makes things worse. And how can we overcome AD stigma? So educating the public. I like to go around and talk about our center because that's the best way to reduce stigma. Knowledge is power. And if you can give people the correct information, it's way easy to be less afraid of something if you understand what it is. And then just our CADRC has a community advisory board that is, we do outreach, we do presentations to try to manage stigma. We go all over town. We have a co-director that's based on the unit and then based out in the community. And I just want to say one final slide before I end. So a lot of what I was talking about was focused on amyloid therapies, and we talked about amyloid and tau plaques. One of my colleagues at Case and University Hospitals has been doing rodent work to look at other biomarkers that are upstream for amyloid, upstream from tau. So those are markers of cell death or cell decline, but work in earlier stage where it's brain homeostasis and it allows the brain to use their cognitive reserve to basically maintain cellular wellness has been very excited. So he published this work this year in Cell, looking at potential mechanisms to maintain brain homeostasis that can minimize or even reverse some of those markers of cellular death like amyloid or tau. So very exciting information on the horizon. 10 tips for healthy aging, all of those modifiable risk factors that we talked about, right? You may not be a candidate or want to do these preventative things. We see that sometimes the cure is worse than the disease with some of these, but we can all get behind doing some of these modifiable things like exercising and eating healthily and getting regular health checkups to reduce our risk for AD. I want to give a shout out to my colleague here, Jackie Whitlaw, at the back of the room. So she can give you more information about our CADRC. We have a whole cadre of scientists working together. And for those of you who are interested in our center, may want to consider signing up for some of our other observational or other types of studies. Jackie's your gal. She'll give you the information. So thanks for being here this morning, Jackie.
Thank you, Dr. Skeptic, for sharing your time and expertise with us. We will now start our Q&A session. So Marlene and Cliff are in charge. Get their attention and they will give you a microphone.
Quick point, 2 questions. One is, do you work with the Cleveland Clinic brain study? You do.
Well, so the Cleveland Clinic Brain Study is actually not part of our CADRC, so we don't work with them. It's an observational study that's been funded by additional philanthropic sources at the Cleveland Clinic. However, we do work with them in that if somebody comes to us and wants to participate, and they may not be an eligible candidate for whatever reason, then we do refer them to the brain health study. So we are, just to give you a little bit of background, so we've had a 5-year grant from the U.S. National Institute of Aging. Our funding ends in June of this year. We hope to be able to get a renewed grant, fingers crossed. You don't see my toes here, but they're but our theme in this new grant submission is identifying factors that impact the rate of progression, right? So that's where currently we are looking at people that have high risk for more rapid progression.
And do you tell your patients, because the Cleveland Clinic does not give a report to the patient on what they find?
So findings are disclosed to patients, but what I would say is these are not the same things as like when you go to get a clinical evaluation. So I think if you are at risk, let's say you have ApoE4 status, and you know that, then you can come and get an evaluation and you will get disclosed your findings. Thank you.
Hi, so the umbrella slide that you have there are like multiple different subtypes of dementia underneath it, right?
Yes.
How important is it to treatment options to know which specific subtype you have? Does that impact treatment at all?
It's really critical. So these amyloid targeting treatments that I mentioned, the monoclonal antibodies, are only for Alzheimer's disease, and they're only for people that have amyloid. So if you have, let's say you've had a head injury and you've got dementia later in life, or you have Parkinson's disease, you would not be a candidate for the amyloid targeting treatment. So that's why it's really critical to get to understand, what is the underlying pathology of your illness.
Is insurance coverage a concern there? Personally, I've run into that where I was basically told like we're not even going to bother testing because insurance won't cover it and it won't change the outcome.
Yeah, so if somebody has a moderate disease, right, and they've got significant impairment that's impacting their condition, they would not be a candidate for amyloid targeting treatments, right? Those are only early on where there's some data or evidence to suggest you might impact the trajectory. And a general rule of thumb is if you're going to do a diagnostic test of some kind, you only do it if the answer to that test will guide your treatment. But if you're going to do the same thing, then it's just more information and many insurers will not cover. If that makes sense.
So I participated a couple of times in Alzheimer's study through the clinic. And initially I was tested for my APOE and I was a 3. And so they took me for that reason. Is it likely that whatever you call it level will stay the same always, or might that change?
So genetic markers will stay the same, but your risk or anybody's risk will be impacted by other comorbidities that they will have. And, the reason I'm so excited by Dr. Pieper's work, which kind of targets brain homeostasis on a cellular level, is that it kind of gets us beyond a sole focus on amyloid. So you have healthy older people who have tons of amyloid in their brain and no cognitive impairment. So they've got the biomarkers, but they're not cognitively or functionally impaired. And so what that tells us is that amyloid doesn't necessarily translate to AD. there are probably some other factors, cognitive reserve or brain homeostasis, that impact what that progression looks like. So, and that's why we need to have the continued research to understand why is it that some people progress and have these biomarkers and others do not.
What are amyloids?
Amyloid is basically a cellular, it's kind of an aggregate. It's inclusions in the cell. I'm trying to think of a good analogy. If your engine is clogged and you kind of got gunk in your engine, right? It's the cell is not able to clear and have its normal biological functioning because it's got these amyloid inclusions.
Dr. Sadowik, would you just allow me to amplify one of the things you talked about, and that was the
Sure.
finger study
Sure.
out of Finland, published in 2014, looking at lifestyle changes to prevent the progression of dementia. There's another study that just came out in July of 2025, the U.S. study sponsored by the Alzheimer Association. And again, what it showed is that we can help ourselves. What I call grandma's medicine, this kind of stuff that we've been told a long time ago that would help us. And that is basically exercise. The brain craves exercise, not just the heart. Diet, which you mentioned, and the Mediterranean diet and the dish diet for people with hypertension, socialization and cognitive challenge, like you mentioned, coming to something like this. And number 4, seeing your physician for maintaining good cardiovascular health. It took several thousand actually, 60 to 79-year-old people who were thought to be at risk for developing dementia, increased risk because of poor lifestyle, and followed them for 2 years, like the finger study. And what they showed is that cognition not only stayed stable, it actually improved in this group. So the important thing is for all of us, because the treatments that we have, as you mentioned, are pretty meager. And exercise, socialization, cognitive challenge, basically taking care of yourself with a good diet in addition, actually can seem to prevent the onset of dementia. And that study continues. The first review was in 2000, or in 2025, but it's now going to, that population is going to continue to be watched. So I consider this really very exciting news. The finger study and the U.S. pointer study. We can do something to help ourselves.
Thank you, Mike. I would absolutely agree that I would hope that folks would come away from this discussion this morning, not to say, oh, we're a few years away from a drug treatment, to say, yes, I can do something now. The whole drug development thing is really exciting. So I would say where we are with drugs now is kind of like we were with cell phones when we had the thing that was like the shoebox size, right? It's got issues, and I think that will improve. But in the meantime, I wouldn't be waiting for a drug, but to do what we can that is simple, but not easy.
We have a question from the virtual audience. Do you know anything about the use of statins to reduce cholesterol and development of dementia over time?
Yeah, so what I would say is managing cardiovascular risk is key, right? Whether it's a statin or whether it's another drug. You saw diabetes mentioned in our slides, right? So managing obesity, managing body weight. If you have diabetes, keeping your hemoglobin A1C within appropriate guidelines. So I would say statins have a role, as they do in a similar role in managing cardiovascular risk. There's been other studies that have looked at different compounds that promote brain health, and I would say, maybe there's some additional potential benefit, but again, I really think we have to look at the behavioral impacts as well as drugs that can help us maintain healthy brains.
What's the definition of exercise? 30-minute walk, I think, or 20 miles a day, what are supposed to do?
Yeah, so that's an excellent question. First of all, let me say that the best exercise is the one that you do. So, there's benefits to strength training and high impact and, resistance training, and those are all good. What Finger and Pointer have showed us that it's really about sustained healthy lifestyle. So what I usually recommend is get out there and walk as being something that everybody can do. And if you enjoy other activities, strength training, those are all good too. The problem is when you set the bar high and it's such an effort to exercise that people don't, then you kind of cancel out your
A question about the diabetes link. I thought I heard you say that there's like sometimes diabetes can be a positive connection. Did I catch that right?
I'm not
maybe
aware.
I didn't.
No,
Okay.
I'm not. Diabetes is generally a risk factor, especially if it's poorly managed or poorly controlled diabetes.
Because I heard that there's potentially a positive benefit to metformin on cognitive health. Is that accurate?
Yes, so there's been studies looking at metformin used in a variety of, brain health generally, mental illnesses. There's some data that suggests you can have positive impact, but again, you're looking at a medication that can cause side effects, and I definitely would not say that having diabetes and being on metformin is a precursor to excellent brain health.
Thank you for the wonderful talk. We hear quite a bit about shingles vaccine and a reduction in dementia following its use. And actually, I've heard about other vaccines having the same benefit. How do you feel that links into the actual pathophysiology or pathogenesis of dementia, if at all? Thank you.
As related to vaccine?
Yeah.
Oh, so I would say that's probably getting outside of my lane a little bit to be able to recommend vaccines. However, avoiding getting sick is a risk, can minimize your risk factors. So I would say to the extent that one would want to avoid having shingles or the flu, would be beneficial. So in general, I will recommend that people get vaccines kind of given standard PCP health guidelines. But I'm not a vaccine expert. I'm not aware of a study on a population level that have looked at, non-vaccines versus vaccinated populations. We may have a natural experiment. We may have a natural experiment with that happening.
Yeah,
Here.
one published study in which they took birthday as the cutoff, and everybody in, and I'm blocking which country it was, maybe it was Finland or Sweden, up to that age they hadn't had shingles, and then on their birthday they got the shingles vaccine, and there was a 20%. It was a natural experiment. It wasn't a double-blind clinical control trial, but it was pretty much as good as one. And they showed this 20% reduction. So
I would take that with a caveat. So, if you look at populations that do not get vaccines, many of them tend to have other risk factors that might promote, you can control to that to some extent, but perhaps not completely. So, but thank you for bringing that up. All right.
On a happier note, we know that brain death doesn't necessarily cause the body to die. What's the usual cause of death in people with advanced Alzheimer's?
They usually die from something else. Pneumonia, falls. Folks with Alzheimer's disease are at very high risk of developing complications when something happens to them. I think the COVID pandemic was a great example of frailty and folks who have cognitive impairment being at.
I ask because you see, cause of death was Alzheimer's. Actually, it's not the proximate cause of death typically.
This is from the argumentarian here. I would say that is true if one were to look at, what you see with people with severe Alzheimer's is they tend to get one thing after another. They go to the hospital, something happens, and then they pass away, perhaps due to a fall or due to a pneumonia or an infection.
You mentioned education. Is that more tied to intelligence or just the extra knowledge you require to take action?
So the studies have looked at years of education and level of education. Here in the US and in many parts of the world, education is a proxy marker for socioeconomic advantage and other protections of brain health. So education is clearly a protective factor, but there's almost certainly other variables embedded in the opportunities that people have to get education. And that might potentially explain, if we look at some of the racial and ethnic minority groups, why their risk for AD is actually greater, because they also tend to have lower levels of education.
So here's just an elemental question. So say I'm concerned about, am I losing it or not? Do I go to a primary care physician? What's the trail of care for this kind of disease?
Yeah, so some of that might be, where do you live, right? If you're in Cleveland and you have access to brain health specialists, I would say go there. Primary care provider will often do an office-based brief cognitive evaluation, take a good history. If that person's on the ball, and make a referral, right? They're not going to be starting amyloid targeting treatments, right? You would need to get in to see a specialist. So I would say, if you're really concerned, we are very fortunate in Cleveland that we do have access to medical specialists who are adept at doing neurocognitive evaluation and the kind of battery that our CADRC does in clinical settings. I would say, just for another plug about the CADRC, this is an opportunity for people to get evaluations. There's also other types of clinical trials. So our CADRC is an observational battery where we test people annually, but don't do interventions. But you're also at that point plugged into the option to get into different kinds of clinical trials that are. I'll be around for a couple minutes if folks want to speak with me.
So I have a postscript to what you said. The Hospice of the Western Reserve has a navigational program, which is primarily for patients that have dementia or that kind of thing. It's long-term. There are patients that have been in this program for like 10 years or so, but it's helpful to both the patient and their caregivers.
Yeah, and so I'm glad you mentioned that. There are other entities in town. So the Alzheimer's Association, which is all over town and has, will do events all over the place, can also help people navigate to, find a provider that can do the kind of assessments that you need, support groups for families. So that, I would put that under the heading of additional lifestyle things that people can do.
I have another question from the virtual audience. If neurological testing is not recommended without symptoms or genetic markers, how can the average person get tested in time for treatment?
So if you have a family history, then that would be an indication to get assessments done. So for example, in our CADRC, if you have more than 2 immediate family members who have a history of AD or at least the ApoE status, you would be qualified to go ahead and get evaluations. So I wouldn't say it's a general blanket. Look at family history is just incredibly important.
Just a comment about exercise that was brought up. The studies that are set up like the finger and the pointer study, they need, just in the study, you have to be able to set up an exercise system that can be studied and followed for results and so forth. So they generally involve resistance training of some form, if you will, weight training, and also some aerobic activity. I think the pointer study was 3 times a week, but what Dr. Sajatovic said is absolutely correct. The best exercise is the one you're willing to do. We really don't know how much and what type of exercise works. Probably all exercise to some degree is of value. That's the most important. In terms of how do people die from Alzheimer's disease, one of the most common causes is the satiety centers are impacted in Alzheimer's disease. A lot of patients in late stage Alzheimer's stop eating. And that's a pretty common way, a pretty peaceful way of passing away. Macabre to bring up, but it's the fact.
Let's thank our speaker again. This is the last of our invited speaker forums for this season. On April 19th, we'll be having a community discussion. So if you want to get up on your own soapbox and say your piece, that's an opportunity. If you would like to receive reminders about our future forums, there's a clipboard and a table in the back, or you can send an email to forums@uucleveland.org. Upstairs, the Sunday morning service, you're welcome to attend, either upstairs or on virtually on our YouTube page. The theme today is Where We Shine the Light by Amy Collins, a commissioned lay minister, and the music will be provided by Mike Carney and the Chancel Choir, with guest musicians Ellen Putnam and Hallie Horowitz on piano and violin. To see what else is happening at UUCC, please check our website at uucleveland.org. Thanks again for joining us today.